कसरत करना है एंजॉय ये
वही
तो एंजॉय
मतलब है,
करता मैं
सेम डिफरेंस है।
and you carry on I shall be listening when there will be tongue I shall make it muted
ठीक है सर, बाय। गुड टू सी यू सर, लुकिंग बेटर ऑल्सो।
स्लाइड विशाल, यू आर शेयरिंग?
हाँ मैं शेयर करता हूँ, बस जैसे आप बोलो, आई विल शेयर राइट अवे।
प्लीज शेयर। आई थिंक शेयर वाज बिजी समवेयर। Full screen we can go. Recording is there. Yes. Yes, we are all set now, I think. Yes. Thank you so much. Welcome all of you to this 263rd edition of Thursday Musings. Today we'll be talking about bipolar disorder in elderlies. So the rules of the game are simple. The meeting is being recorded. Everyone will be on the mute mode. Your questions are invited in the chat box. So you have to type your questions and put in the chat box for the speaker to take it up. Then yes. So let me introduce Professor Dr. Tufan Pati sir. He is the chairman of this program since the inception. Since Dr. Tufan, next slide please. Dr. Amrit is the co-moderator. Both of them are busy in the CZIPs. So in their absence, please allow me to start. Myself, Dr. Alim from Lucknow. Next slide. Shobit, Dr. Shobit from Dehradun. And Dr. Vishal from Delhi. So all we are the moderators and the teams. My pleasure and honor in welcoming the chairpersons of this program, Dr. Mamidipalli Sai Spurti. He is currently assistant professor at AIMS Bibinagar. He is MD Psychiatry from PGI Chandigarh, senior resident at AIMS Raipur. Huge number of publications, 50, H index 9, citations 2243, 11 book chapters, assistant editor for the book of IPS at 75, peer reviewer of 10 journals. Multiple awards and recognitions such as Travel Award for Schizophrenia, International Research Society Conference at Italy, Young Psychiatrist Award at Pacific Rim College of Psychiatrists Conference in Myanmar, 2018, Young Scholar Fellowship in World Congress of Asian Psychiatry, September 22, Marfatia Award co-author and SIPS 24, P. Raghurami Reddy Award, West Research Protocol, IPSOCON 2025. Area of interest are schizophrenia, geriatric psychiatry, and suicide. Welcome, Dr. Spurti. Next slide, please. Dr. Neha Agrawal, she is MBBS from Sardar Patel Medical College, Bikaner, MD Psychiatry Gold Medalist from Government Medical College, Amritsar, did her SR ship from SGRD Amritsar and VS Hospital, Delhi, Kent, currently working as consultant for Fortis Hospital, Manesar. So welcome both of the chairpersons. The meeting is now over to you. One person may introduce the speaker. Both of you may introduce the topic. Next, over to you. Chairpersons, please take over.
You have to introduce the speaker first or later on?
Yeah.
Good evening, everyone. I would like to begin by thanking the organizers for the opportunity to chair this important session on older age bipolar disorder evidence to treat. It's a privilege to be among such esteemed colleagues to reflect on a topic that is both evolving and deeply relevant in today's psychiatric practice. Older age bipolar disorder or OABD refers to individuals aged 50 years or above living with bipolar disorder, a definition which was recommended by International Society for Bipolar Disorder. This age threshold recognizes that people with bipolar disorder experience accelerated biological aging and often have a 10 to 20 years shorter life expectancy than the general population. What makes OABD particularly important is not just age, but complexity. We are now seeing two distinct clinical pictures: those who have lived long with bipolar disorder and those with late onset illness emerging for the first time after midlife. Both of them bring unique challenges. With advancing age come changes in pharmacokinetics, increased sensitivity to side effects, multiple physical comorbidities, and a greater vulnerability to cognitive decline. Studies suggest that nearly 40 to 50% of older adults with bipolar disorder show measurable cognitive deficits, even in the euthymic phases, affecting the memory, attention, and executive functioning. Beyond cognition, OABD patients often struggle with social isolation, reduced autonomy, and poorer quality of life, even when the mood symptoms are well controlled. Hence, the focus of treatment today is not only symptom reduction, but also functional recovery, helping the patients maintain independence and social engagement. We have seen large collaborative efforts like GAGE, BD, Global Aging, and Geriatric Experiments in Bipolar Disorder, the project which has been pivotal in older age bipolar disorder. And it has data from over 2,000 patients worldwide, which shows that traditional distinctions such as bipolar 1 versus 2 or early versus late onset lose much of their clinical relevance in older age. What truly matters at this age is a holistic, integrative model of care, one that simultaneously addresses physical health, cognition, and psychosocial well-being. As psychiatrists, our challenge is to move from a purely symptom-based to a multidimensional treatment approach, coordinating with physicians, neuropsychologists, neurophysicians, and caregivers. The goal is to improve not only the longevity of those patients, but also quality of years lived. With this brief overview, it's my pleasure to introduce our co-chair, Dr. Sai. She can also introduce our speaker for the day. Over to you, Dr. Sai.
Thank you, Dr. Neha. First of all, good evening, everyone. I would like to thank the organizers for giving me this opportunity, prestigious opportunity, I would say. So, with the brief introduction that Dr. Neha has given, so when I heard about the topic that is older age bipolar disorder, there are so many questions which came into my mind. Similarly, you all also must have got so many questions like, will the symptoms be the same? Will the presentation be the same? Will the treatment be the same? What is different? Can the same guidelines that are being used for adults be extrapolated to the older age bipolar disorder? What are the diagnostic challenges? What are the treatment challenges? So the main issue is balancing efficacy and safety in these individuals. So with this brief introduction, so let us see how Dr. Vidya will continue the session and lead us through evidence from evidence to practice. I'll just introduce her. Dr. Vidya KL has done her DPM, DNB Psychiatry, DM in Geriatric Mental Health. She's currently working as Assistant Professor, Geriatric Mental Health Unit of KGMU, Lucknow. She has 15 plus years of experience in psychiatry. She worked as senior resident and assistant professor at CIP, Ranchi. Her awards are Sharda Menon Gold Medal Award in DNB Psychiatry, Indian Association of Biological Psychiatry IABP Award for Best Research Paper, World Congress of Asian Psychiatry Young Scholar Award. I cannot see the slides. Yeah, thank you. So her publications are Sweta Tiwari Memorial Award for Best Research Paper. She has more than 20 publications in Index Journal and 7 book chapters. Her interest areas are neuromodulation, late life mood disorders, and healthy aging. So without further delay, I would request the speaker, Dr. Vidya, to please start the session. Thank you.
Thank you, Dr. Sai, and thank you, Dr. Neha. That's, I think, I'm not able to share my screen. Yeah. Yeah, I hope that it is visible now.
Yeah, it's visible now.
Yes, yes, you can just post it.
Yeah, yes. So, yeah, thank you, both the chairpersons. And I think both the chairpersons have summarized what I'm going to speak in the next 40-45 minutes or so. And so before I begin, I would like to express my thanks to the organizing team, especially Dr. Alim, Dr. Amrat, Dr. Vishal, and Tuban Sathi sir, and of course, Dr. Shobit sir, And I would like to express my gratitude to my alma maters, both past and the present one. This is the outline of my presentation. I will be dealing with the background at the beginning, and that is about how OABD is different, aging changes which are relevant clinically, and then about section 2, that is about the evidence and challenges. Finally, about the recommendations for safe practice. To start with, what exactly marks older age? There is no universally agreed upon cutoff age for elderly or old age. United Nations considers older persons as those who are aged 60 years and above, and in India, we follow the same. Few developed countries consider 65 years as the entry age. For today's context, International Society for Bipolar Disorders defines older age bipolar disorders as bipolar disorders occurring in patients aged 50 years and more. And if I have to speak about few more relevant factors, that is about, first one is older age bipolar disorder is a broad term. It also includes patients who are having early age onset bipolar disorder and late onset bipolar disorder. And the distinction for this particular thing is cutoff age of 40, either before or after this. Now I said about 40 years, I said about 50 years, 60 years, and 65 years. So if I have to say, is it just a number? Well, here there is biological aging, which is happening along with the bipolar disorder. So this comes with the cumulative burden of multimorbidity, frailty, and pathological aging, because of which there is reduction in the average lifespan of 10 years. That is why the cutoff age of 50 is considered by ISBD. Despite this decreased average lifespan, currently older persons constitute 25% of the bipolar disorder patients. And soon, by the year 2030, half of your bipolar disorder patients will be aged 60 years and above. And now that is the magnitude of older persons with bipolar disorders needing treatment. It's only 5 to 10% of the individuals with bipolar disorder will be 50 years and above when they get their first manic episode. Even less than 5% have onset above the age of 60 years. So the major chunk, as Dr. earlier said, it is a survivor cohort of early onset bipolar disorder. So what constitutes OABD is, first of all, survivor cohort, then comes the converters to bipolar. That is, those who had unipolar depression now switch to manic episode in the later life. Then comes the late onset first episode mania or late onset bipolar disorder, who constitute less than 5 to 10% of the cases. And this also includes secondary mania, where the late onset mania, that is secondary to medical or neurological events. Now, the secondary mania is really a small proportion. Why discuss this topic for 1.5 hours? Well, for this purpose, I would like to narrate one small, simple case vignette that needs clinical decision making in your busy OPD in terms of clinical diagnosis as well as plan of management. I expect the audience to respond in the chat box so that I can see the response, and I'll pause whenever there is clinical decision making for about 10 to 15 seconds. And then I'll move forward. So just listen to the case vignette, which goes like this. Mrs. P, 66-year-old retired teacher living with the family. She's a known case of bipolar affective disorder. She was maintaining well on lithium, 600 mg per day, sertraline 50 mg per day. Her last episode was about a year ago, which was moderate depressive episode. It remitted with treatment from a local psychiatrist. She is also on L-troxin, 100 micrograms per day, oral hypoglycemic agents, and antihypertensive for hypothyroidism, diabetes mellitus, and hypertension respectively for last few years. Now for last 1 week, she was found not sleeping at night. She is irritable. There was increased activity. She was found to be sweeping, cleaning, and she is doing excessive puja at the middle of the night. For last 2 consecutive evenings, she insisted that her daughter-in-law prepares prasad to be offered to gods who have visited home. Family is known family knows about the bipolar disorder and got her serum lithium estimation done. And next morning, they reached your OPD. Now, when you examined, there is mild pitting pedal edema, there are tremors, BP is 108/70, and the rest of the physical examination findings were within the normal range. Mental status examination revealed increased psychomotor activity. Her attention was aroused, was easily distractible, oriented to time, place, and person. She is irritable. However, no abnormalities of thought could be elicited. You could elicit just fleeting auditory hallucinations and visual hallucinations. Her serum lithium level is 0.6. Now the question is, what is the diagnosis? So here I will pause for maybe about 10-15 seconds. I would like you to respond in the chat box. What do you think about the diagnosis? Yeah, is it manic episode? Yes, and anyone else? I can just see one response here. Manic episode. Yeah, is there anyone else thinking otherwise? Switch? Yes, she's on sertraline. Of course, we will think of switch. Manic, I think we have 3-4 answers about manic switch. Well, if I move further, maybe, yeah, we think about manic switch and the majority is thinking about the manic switch. So if I have to go to the next slide, that is about, sorry, just 1 minute. Yeah. So meanwhile, if I have to say, if there is any more information, yes, while examining, you saw the pedal edema and family gives additional information that they visited a cardiologist and cardiologist blamed the antihypertensives for the edema and it was changed. And the family forgot to bring the prescription. Family also report that the edema has decreased now, but urinary frequency has increased. Now, what is the next plan of management? I'll pause here for a while and wait for your response. Okay, in between, I think I see a few more responses who say about, yeah, yes, there are a few more responses. Hyperthyroidism, yes. Rule out underlying organ problems, yes. Probably drug-induced switch. Drug interaction reduced efficacy of lithium, interesting. And manic episode, pedal edema. So, okay. Yes, KFT and TFT is important. Drug-induced hypomania. I think, yeah, Dr. Victor D'Souza says that. Rule out delirium. I think it's Alka, ma'am. I'm not sure. Dr. Alka. And stop SRT, of course. Yes. Due to electrolyte disturbance. Yes. Drug toxicity. Excellent. So, yes, stop sertraline and add antipsychotic. Excellent. So, yes. Now moving on. Yes. Yes, as the plan of management goes, following, I think the majority of the people, as suggested, you stop sertraline. Maybe for sleep was an issue, so you add antipsychotic low dose, quetiapine 25, and you continue L-troxin, and you continue lithium because majority felt it is a manic switch. Maintain hydration because she is on lithium, and bring the ongoing medicines. We need a brown back review here. We sent lab investigations, including a repeat serum lithium estimation, and we asked the patient to come with reports as soon as possible. I'll move on to the next stage where patient is brought back in 4 days. Her condition has worsened. She has confusion, tremors have worsened. She falls on trying to walk, not identifying family members, and she's falling as she's trying to get up and speak. There is slurring, and her pulse is 110 per minute. BP is 90/60. There are coarse tremors. Now, impression. Of course, I will not wait for the chat box. I think all of us understand at the moment that she's having delirium. Now, the brown bag review. We go through each and every medication, what is there in her bag. She is on glimepiride 2 mg per day, metformin 1000 mg. She is also on Telma H. This is the antihypertensive, which was changed by the cardiologist. She is on hydrochlorothiazide, which is added. Probably amlodipine was changed to hydrochlorothiazide. She is on entroxin, which we have continued, lithium, quetiapine, which we added, and also she is taking Overon SR and a diclofenac, which is given by a local pharmacist for her knee pain. Now I'll move on to the positive findings in the lab test. We have done an extensive lab investigation. Her serum lithium estimation level has gone up 0.82. Total count is 12,800. Neutrophils are 84. Sodium is 121. We already had someone mentioning about hyponatremia in chat box. She also has elevated urea. She has elevated creatinine. Her HbA1c is 8.2. Someone had also mentioned about hyperthyroidism. Well, her TSH, T3, T4 levels were within the normal limits, so it is not mentioned here. Her urine culture was also done because there was urinary frequency which was increased too. So we got E. coli with more than 1 lakh colony count. Her ECG had conduction abnormalities. So this is one simple case of bipolar affective disorder who had responded to lithium, who had comorbid diabetes, hypertension, hypothyroidism, now has presented in delirium. She has severe hyponatremia. She has urinary tract infection. She also has lithium toxicity. Clinical signs are present, but the lithium levels are in the therapeutic range. Let's discuss about it in a while. And probably she also had acute kidney injury. This is how even a simple early onset typical bipolar disorder, which responded well to lithium, can go downhill and land up in medical emergency. So acknowledging the aging changes and modifying the approach is crucial. And now that is the importance of this topic on old age bipolar disorder, which I'll be mentioning as OABD now onwards. That is where I'll be discussing mainly about the relevant pharmacokinetic, pharmacodynamic changes mainly, and pharmacological management I'll be focusing more because I think going into the non-pharmacological management will take longer time. So starting with how OABD is different. First of all, as already chairpersons mentioned about physical comorbidities. Yes, on an average, 3 to 4 comorbid medical conditions ranging from metabolic syndrome to even movement disorders. Of course, it comes with the bag of polypharmacy. So they are at the increased risk of drug toxicities. Changing course of illness with age. Natural course of illness changes with age, and frequency of episodes change. Depressive episodes become more frequent, they are prolonged and associated with psychosis. Manic episodes are less and severity is also less. Interestingly, this global aging and geriatric experiments in bipolar disorder cohort suggest that both depressive and manic symptom severity may be reduced with old age. And so as already mentioned by Dr. Neha, that this suggests that distinction between the type 1 and type 2 may be clinically less relevant here. However, the mixity is very, very crucial here. Up to 70% of the patients have mixed manic and depressive symptoms of varying severity, because this is important because the definition of and concept of mixed episodes have been changing over the time. Clinical presentation also changes. There are overlapping symptoms, there are atypical symptoms, masquerading symptoms, they increase, all reporting as different case reports. Hyperactive delirium can mimic mania, probably what we saw in the case vignette, which we discussed just now, and it can happen vice versa also. Depression and hypoactive delirium also becomes challenging to differentiate. And depressive episodes also present with psychosis and catatonia. Many times psychosis and catatonia is in the forefront and depression remains masked. As mentioned earlier as well, cognitive overlap, cognitive decline definitely poses challenge. It could be age-related decline, it could be MCI, or it could be even dementia. Then there comes differentiating pseudo-dementia versus dementia. That is another challenge. Even substance use and suicide risk is also higher. However, getting the exact data is highly difficult, as with any other geriatric case. Substance abuse, basically, it is benzodiazepine dependence. Mostly, it is the prescribed one, which is then patient conveniently takes more and more. And suicide risk is highly unpredictable. There are more lethal attempts, and we get lesser second chances. Another interesting thing, which is different in OABD, is pattern of precipitating factors. We talk about psychosocial factors in the adult age group, but here it is underlying acute medical illness. It could be infection, it could be metabolic derangements, it could be polypharmacy, or anything that is added by a GP, any other new drug that can also precipitate. And so exploring the diagnosing the root cause is extremely important, so is treating it. Interepisodic functioning also depends on physical health, cognitive health, and psychosocial functioning. So clinical course can be highly variable depending on all these confounders. Finally, about the secondary mania. This is something which is dramatic. Probably this is what we read when we read about older age bipolar disorder at the level of post-graduation. But this is really a small portion of older age bipolar disorder, where there is late onset or very late onset first episode mania. Definitely, it is because of some structural cause or polypharmacy or anything that is underlying medical thing, which is precipitating the mania. So definitely, the integrity of frontal limbic basal ganglia circuitry is essential for maintaining a normal mood. Whenever that is disrupted, it can present as secondary mania, especially in the right-sided lesions. So we need to keep a differential of delirium, which we just saw in the this case survival cohort of case vignette we discussed also. Delirious mania, psychosis in dementias, behavioral variant of frontotemporal dementias, traumatic brain injuries, substance or drug-induced, even prescribed drug-induced manias, right-sided stroke, severe metabolic derangements also. Finally, another important thing is toxicity occurs at the therapeutic serum levels. It can occur silently, literally, and figuratively. We'll come to that in a while. There's lot of things which are different. And now let's see why it is different. The aging changes which are clinically important for management of OABD, I'll be discussing only a few of them. First one is declining renal function. 35% of the renal function is lost by the age of 65 years, and 50% is lost by the age of 80 years. And serum creatinine urea can be misleading in elderly because there is decreased muscle mass, less production of creatinine. So it is important that we go for eGFR. That is more reliable indicator. Renal clearance of drug reduces and the half-life of most of the drugs increases. So your calculation, what you do for adult population may not work here. Another important thing is fluid electrolyte homeostasis deranges, which is known as homeostenosis, where there is decrease in aldosterone, and that affects the sodium retention in the kidneys. Kidneys are responsive to the antidiuretic hormone. So upon which there is vulnerability for dehydration, hyponatremia. So risk of drug-induced hyponatremia increases, risk of SIADH also increases. Further, there is frailty, decline in muscle mass, total body water, and hypoalbuminemia. Because of this, volume of distribution is reduced, protein binding is affected. So there is unpredictability of serum drug levels. There is dysregulation with regards to parathyroid hormones as well, exacerbation of osteoporosis, especially important for lithium and valproate, and of course, altered absorption and distribution profiles also contribute to unpredictability of serum drug levels. There is sluggish gut motility, which further complicates hyperammonemia, especially important for valproate. We can get hepatic encephalopathy there. Another important thing is about changes in the brain to serum ratio of drug levels. So as patients age, blood-brain barrier permeability changes, and it can result in CNS concentration being more than the expected thing. So this creates a little bit of confusion. Further, there is another confusion, which is created by valproate, which is highly protein bound, and in adults, free fraction is only about 10%, but in old age, it increases. So total valproate level may be in the therapeutic range, but free valproate level, that becomes more important even in older adults. Psychodynamically too. So aging body treats psychotropics differently, and it's also the drugs treat the body differently. There will be receptor densities, sensitivity changes, and neuroleptic sensitivity is higher. Supersensitivity of the receptors also because of long-term exposure to antipsychotics, especially in the survivor cohorts. And some of these things can unmask the latent Parkinson's. Further, so to summarize, these changes, they all occur at a different variable speed. There is no homogeneity in aging. Confounders are limitless. Generalization becomes extremely difficult, and that is what makes OABD more challenging. So yes, I have spent half of my time on the section 1. So as to summarize it, OABD fundamentally differs in a lot many ways than bipolar disorder in general adult population. And aging changes affect both pharmacokinetics and dynamics of most of the commonly used drugs in bipolar disorder. To ensure safe and effective management of OABD, it is important that we ensure evidence-based practice. These are basically very important basic stuff. That is the reason I spent the maximum time on this, the background and the basic details. Now, coming to the evidence-based practice specific to OABD, the guidelines, if we look at the guidelines, they are limited. Most of the guidelines are limited to, few sentences under the special population category, only 2-3 sentences. The maximum what we find is in the CanMet ISBG guideline. That includes a separate section about a page addressing the special population, which has maybe a page dedicated to older adults. That's the maximum we get. And no other specific guidelines for the management of OABD till date. So, as the chairperson discussed earlier, this is about extrapolating the general guidelines for management of bipolar disorder, and they do not have any extensive separate algorithms for older patients. If you look at the treatment options, first line, second line, third line agents, lithium, valproate, lamotrigine, atypical antipsychotics, yes, antidepressants which with lower switch potential, of course for treatment resistant CCT and clozapine. not really different than the adult population. So lithium remains the first-line agent, be it for acute mania, be it for long-term maintenance, or even in agitated depression. It also further decreases the risk of suicide. The interesting part here I would like to discuss about is this efficacy. See, all these, whatever the data what I have given, they have been extrapolated from the adult population or the mixed age study. So when we look at the geriatric specific data, the efficacy of lithium in elderly, for that, if you look at this particular graph, this is the data from JERI-BD trial, wherein a double-blind RCT, which compared between lithium and valproate, found that lithium was superior to valproate in reducing the YMRS score over the time. Now, there are certain advantages of for using lithium in elderly. That is because, as already mentioned earlier, that bipolar disorder diagnosis itself increases the dementia risk up to 3-fold. And it is found that long-term lithium exposure is associated with 50% reduction in the dementia risk in comparison to other psychotropics when compared to antidepressants, antipsychotics, or other mood stabilizers. So it has some protection here. Additionally, there are few other studies which are ongoing. That is, one is Lattice study, which is finding out the pro-cognitive effects of lithium. However, the findings are preliminary. If you look at the lithium further, it has minimal efficacy when it comes to secondary mania, late onset mania, with MCI or BPSD manic symptoms or vascular mania. Now, if you look at the anticonvulsant mood stabilizers, definitely they are alternative to lithium. First comes valproate, that is increasingly being used in older age bipolar disorder. However, there is no evidence for its greater efficacy or even for greater tolerability when compared to lithium. Probably, yes, rapid cyclers may respond better with valproate as with general adults. Lamotrigine was found to be effective in bipolar disorder. However, the randomized controlled trials are rare. If you look at the efficacy of other anticonvulsant mood stabilizers, they lack controlled studies in geriatric specific populations, so they cannot be recommended routinely for these individuals. Then coming to the antipsychotics. Atypical antipsychotics, be it quetiapine, olanzapine, risperidone, aripiprazole, they have good evidence in general adult trials and also some of them for bipolar depression. Quetiapine is highly recommended for mixed and depressive phases in guidelines. However, again, direct or older only RCTs are there. So it is more of extrapolated from a mixed age population. Antidepressants used in bipolar disorder remains controversial. However, it is found that manic switch from SSRIs and bupropion is relatively less when compared to adult population in older adults. So we use antidepressants more often, even in bipolar depression in older adults. Then, of course, the ECT. It is highly, highly underutilized. It is efficacious, safe treatment option for elderly, for depression, treatment-resistant cases, suicidal patients, and even for acute mania where there is rapid symptom resolution which is needed. If you look at the newer molecules, of course, the endoxifen, which is a PKC inhibitor, is used for acute mania. Of course, ketamine, rapid reactive NMDA modulator, used for bipolar depression. There is some data, of course, the quality of data is not great. And then about cariprazine, that is also used in mania, mixed episodes, and bipolar depression. Lumateperone for bipolar depression, geriatric specific data is lacking. If you look at the nutraceuticals, yes, it is up to 71% of the older population were found to be having B12 deficiency, and up to 35% of the patients were found to be having D3 deficiency. So nutritional interventions in these patients were found to be having improvements both in affective and cognitive domains. The quality of these data are slightly limited because of the small sample sizes. Well, indications and efficacy are same as adults, but aging body and medications treat each other differently. So management of older age bipolar disorders depends more on tolerability and safety than just efficacy. Now, if we look for the evidence for safety and tolerability in older adults, most clinical practice guidelines have given the same hierarchy of pharmacological options as I mentioned before. Same evidence base, but they mention that it's to be adjusted for age-related physiology and priority. And that is the reason I spent the maximum period of time on the basics of pharmacokinetics and dynamics in older age. Yes, as I mentioned earlier, the homogeneity of aging is absolutely doesn't exist. Confounders are limitless. So these things make generalization extremely difficult. So this demands person-centered care or person-centered holistic approach. Well, numerical age, just as such, doesn't pose any risks. This is what most of the studies say, and also the safety of tolerability studies which are reported, they are even in elderly, few of the studies, they say these drugs or molecules are safe, tolerability is good. However, they are conducted in very chosen, it's like quote unquote chosen subjects with stringent selection criteria. So how far we can apply these to real life scenario is the question mark. We are not sure about it. So that is what another thing which makes OABD more challenging. So that brings me to the other part of the second section, that is about challenges while managing OABD. As I mentioned earlier, the first challenge is burden of drug-to-drug interactions. Yes, when it comes to lithium, we all know, we all have read about thiazide diuretics, okay, should not be given. But we all have read about NSAIDs. But it is also not only these two drugs, there are other antihypertensives like ACE inhibitors, which is very, very commonly used in elderly, something like telmisartan. That also increases the serum lithium level. 2023 Beers criteria from American Geriatric Society strongly recommends against simultaneous use of lithium with ACE inhibitors, including telmisartan, angiotensin receptor blockers, and diuretics in older patients. Moving on, there is also aspirin, which is very commonly used in older adults. That increases the level of valproate. And valproate, when combined with benzodiazepine, it increases confusion, increases the fall risk in elderly. So yes, there is a lot of confusion which is happening, not only in patients, but also in clinicians, because a lot of interactions. So it is always, when you are in doubt, it is better to quickly check through the drug interaction checkers, which are freely available online, be it drugs.com or Medscape or Medcal. Quickly, it is better to have a check. Better to be precautious than be sorry later on. So the second challenge is high vulnerability to toxicity. It is said that biggest predictor of lithium toxicity is addition of a new molecule that interacts with lithium. This is what we have seen in our clinical unit, which we discussed earlier. It is not age, or it is not the medical comorbidity by itself. So briefly, I would like to discuss about lithium toxicity here. When it comes to lithium toxicity in elderly, it is chronic toxicity what we are talking about, which is more common. It definitely causes confusion, not only in patient, but also in clinicians. Because most of the time, the serum lithium estimations, what you do, they are in the normal therapeutic range. Initial signs would be, or symptoms would be, just inability to sustain focus. Shift attention, complex attention is something which is earlier on gets affected. And tremors of the extremities, ataxia, of course, then delirium, they quickly move on to delirium and seizures. And GI symptoms, which are usually seen in adult lithium toxicity, may not be that evident in older adults. Anorexia may be the only symptom of GI in older adults. And so it is always better that we rely on CNS toxicity signs more than the serum level. That is the reason when it goes unnoticed, risk of silent, which I mentioned earlier, literally and figuratively, syndrome of irreversible lithium effectuated neurotoxicity is very, very common in elderly. So timely active intervention can prevent it, and the irreversible damage can be prevented. Next, about valproate toxicity, I'll briefly mention. This also can happen in the therapeutic range. As already mentioned, it is the more important thing here is the free valproate level, not the total valproate level, because hypoalbuminemia is very common in older adults, and so free valproate level is more reliable. Third one, important thing is long-term effect of psychotropics, the survivor cohort. They are on lithium for decades together. Renal toxicity, nephrogenic diabetes insipidus is more prevalent in older adults. And thirst response is usually affected in older adults, and further it predisposes them to hypernatremia also. This is where the osmolarity profile becomes important. Check for urine osmolarity, serum osmolarity, and this also demands a collaboration with the nephrologist. Long-term exposure to valproate. Already they have osteoporosis, valproate exacerbates it. Chronic hepatotoxicity, hyperammonemia, and further thrombocytopenia. Especially, most of them are on aspirin, and some of them may be receiving SSRIs. Psychotropic, antipsychotics, long-term exposure can, most of them do have tardive dyskinesias, metabolic syndromes, and overall, most of the side effects are exacerbated, like in general, sedation, fall risk, tremors, aggravation of Parkinsonian tremors, or independent extrapyramidal symptoms, and hypercalcemia, osteoporosis, and of course, hypothyroidism that also occurs in younger adults. Hyponatremia, SIADH, secondary to SSRI, oxcarbazepine if you're using it. So cumulatively, if I say, all these challenges, they demand change in the treatment targets. Here, it is not the rapid symptom control which is important, but minimizing the adverse effect is extremely important. Focus shifts from remission or symptom elimination to minimizing sedation, risk of falls, fractures, cognitive reservations, and maintaining quality of life, functional independence in terms of activities of daily living. Focus shifts from early treatment of side effects to active monitoring and reducing the anticholinergic burden and preventing the prescription cascade. This is extremely important. So finally, I'm coming to the third section and the last section of this presentation. That is about the recommendations for safe practice in OABD. Tolerability and preservation of cognition, mobility, independence, and quality of life takes precedence. I'm repeating this sentence again and again. So first, do no harm. That is the extremely important thing. So if I have to take you through the general recommendations for safe practice in OABD, the first and foremost is diagnosis and initial treatment. As we saw in the previous case vignette, always exclude delirium. Even when you for sure, give a second thought, exclude delirium. Rule out secondary mania in those late onset and very late onset cases, looking for structural, vascular, metabolic causes before labeling them as primary bipolar episodes. Physical examination, including a thorough neurological examination, because that is what helps in analyzing the risk and benefit. Look for underlying the medical illness as precipitating factors. Actively look for, I'm repeating this sentence again and again, I can't stress it enough. Look for underlying medical illness as precipitating factor, diagnose and treat if there are any. That is extremely important here. Cognitive assessment, definitely important. Brown bag review of all ongoing medications. Literally, dawai ka thela utha ke laiye, including the over-the-counter drugs. Most of the elderly are taking the over-the-counter drugs, especially painkillers for pain here and there. Whenever there are, it is applicable, attempt deprescribing. Deprescribing is highly, highly rewarding in older age group, whether it is bipolar disorder or otherwise. That brings me to the point of deprescribing as intervention. Whenever there is polypharmacy, especially with high anticholinergic burden and potentially inappropriate medication, attempt deprescribe. Whenever there is risk that is overweighing benefit, deprescribe. Especially reducing the sedation is important, reducing the fall risk. Whenever there is electrolytes going here and there, you're not able to control, I think it is target. One of the prescribed medication is at fault most of the time. And tremor, if it is not interfering with activities of daily living, probably refrain from treating it. Reduce the dose, replace the drug rather than treating the adverse effect. Deprescribing definitely avoids the treatment cascade and it improves safety. Deprescribing is not stopping treatment. It is just tailoring it to the aging body and brain. The fourth thing is investigate. Investigation becomes more important in older adults when compared to younger adults. Younger body is more forgiving, but the older one is not. And symptoms are masquerading. So that is the reason it is always a good point that we have to go for investigations. Basic investigations, hemogram, renal, whenever renal tests are done, it is eGFR, which is more important. Serum electrolytes, extremely important. Thyroid functions, LFT, including platelet count, especially for valproate. Lipid profile. Lipid profile, I wouldn't go for maybe in advanced stages, but in the young old, it is important. ECG, neuroimaging, whenever there is suspicion of secondary mania. The fourth important point is psychoeducation of patient and the caregiver before initiating the treatment. This is extremely important. Can't stress this point enough. Explain what drugs are being given and what steps to be taken when patient is having fever, diarrhea, or headache. Explain. Stress the importance of adequate hydration, electrolyte. Toxicity signs. See, maybe in adults, they are different. In older age, they are different. Even for the survivor cohorts, explain about confusion can be one of the earliest signs of toxicity. And addition of any medications have to be discussed with the doctor and especially when they are on lithium. And frequent monitoring is extremely important. This has to be educated to patient and the caregiver. Fifth point is follow the geriatric prescription practice, which is ideal. That is the same old maxim. Yes, we may find it cliche, but it is extremely important. Start low, go slow. Monitor lab parameters, monitor cognition, gait, and fall risk. Attempt comprehensive geriatric assessment whenever possible and keep watch on anticholinergic burden, which prevents prescription cascade, and that is to be attempted as far as possible. If I have to mention certain specific recommendations for use of lithium, because that is the first line agent. Yes, of course, there are no geriatric specific recommendations, but there is one consensus survey conducted by ISBD, which is recently reported. So they have come up with certain guidelines where before the initiation, they recommend, of course, EGFR, electrolytes, including calcium, and also, whenever possible, measurement of cystatin C. This is a better indicator when we are calculating EGFR, especially, as I said, creatinine can be misleading in elderly. This is the lithium dose recommendation. The important thing is about the ISBD thing, which is in the fourth row. That is the initial, the starting dose only Maudsley gives, that is about 100 to 200 mg to be started, and maintenance dose up to 75 years of age, it is 300 to 600 mg per day, and 75 years and more, it is 150 to 300 mg per day. It is very, very low. And this is something which is to be kept in mind. Then about serum lithium level recommendations, that is for up to the age of 79, it is 0.4 to 0.8. Even if we consider this, the previous case what we discussed still had in the lithium level was still in the therapeutic range for elderly too. However, patient had developed lithium toxicity signs in the patient. And for 80 years and more, it is 0.4 to 0.7. Because as I said, that even in the therapeutic range, the patient can still have toxicity signs. So it is better to rely on the signs more than the serum level. And for serum valproate level, as I already mentioned, pre-valproate level, that is more important. And again, rely on the clinical signs more than the lab parameters. So when we look at the monitoring for lab monitoring, yeah, GFR, electrolytes, and whenever there is concern, urine osmolarity profile has to be checked. For valproate specifically, platelet counts are important, coagulation profiles are important, and serum ammonia is important. And whenever there are concerns, serum ammonia, serum amylase, and bone profile, that is when there is, if for those who are having osteoporosis risk, especially vitamin D3 and calcium levels have to be checked. This is one chart which I thought of sharing, that is about monitoring for atypical antipsychotic. ECG becomes important, and for SSRI, we have to look for platelet counts and serum electrolytes, because hyponatremia is one common side effect. Drug toxicity is definitely preventable if we follow all these steps. Again, if I have to repeat, 3 core principles. The first one is ongoing lithium and valproate related monitoring. Second thing is patient psychoeducation. See, it's not only the converters to bipolar disorder, old age bipolar disorder, or the new onset, late onset bipolar disorder who are needing this psychoeducation. Even the survivor cohort needs special mention and remind about that the changes of happening in the aging body. Because these people are on lithium or valproate for decades together, they think that they know, they have been educated about the toxicity signs or the relapse and so on, but aging body changes everything. So these people need, specially, they have to be educated about the change in demands. Third point is about collaboration with other prescribers, because addition of a new molecule increases the risk. Well, before I conclude, I would like to tell about the limitations. That is, there is a huge gap when it comes to clinical practice guidelines with regards to management of OABD. Even the existing ones, they lack consistency. And definitely we need age inclusive and as well as the geriatric focused clinical research and practice guidelines. I would conclude with these take-home messages. I may be repeating the same things which I have shared before. That is starting with OABD, which it is definitely, it differs from bipolar disorder in general adults and it poses diagnostic therapeutic challenges. And medical comorbidities are rules and exceptions, but many a times medical acute morbidities, they remain silent in older adults, but they act as precipitating factors in OABD. So looking for the root cause is extremely important. Less is more in elderly. Brown bag review of medications and deprescribing to prevent prescription cascade is crucial in elderly. Treatment goal shifts from symptom elimination to preserving cognition, function, independence, quality of life, and safety. Special mention about lithium, which remains as first-line agent, but it needs caution. Biggest predictor of toxicity is addition of a new drug. It is preventable, so we need to educate the patient and the caregiver, and there is need for regular monitoring. Liaising with medical specialists is important when managing, especially those elderly who are frail and having multimorbidity, and they are on lithium. Yeah, that's all from my side, and I look forward for listening to your contributions and learning from you all. Happy to take questions as well.
Thank you. Thank you, Dr. Vidya. Thank you for a wonderful presentation. Over to chairpersons for the opening remarks. Questions are invited in the chat box. So you all can post your queries in the chat box.
Yeah, that was an excellent and comprehensive presentation, Dr. Vidya. That the extent of literature that is available and the time that you have, you try to make it as concise and as informative as possible. I think you touched upon all the important aspects for the participants per se. Among all the things that Dr. Vidya has mentioned, the one important take-home message from today's presentation will be the brown bag review. Any person with any psychiatric illness, apart from bipolar disorder also, so the important thing that we should do as clinicians is reviewing their medications one by one. So with that, I would just like to summarize what Dr. Vidya has already said. So this is an umbrella term used for a group of condition that is older age bipolar disorder. So the evidence again is being extrapolated from what exists for adults. So we start low, go slow, and do no harm. So always look at whatever drug-drug interactions with other drugs that the patients are receiving for other medical comorbidities. There are higher chances of toxicity. Better to avoid polypharmacy. A number of differential diagnoses can be considered ranging from bipolar disorder to dementia, delirium, organicity, so on and so forth. And one more important point is focusing on the synergistic side effects when we are giving combined medications or when we are prescribing polypharmacy. And one more point which is not to be forgotten is psychoeducation, lots and lots of psychoeducation. With that, I hand over it to Dr. Neha.
I'm audible now. Thank you, Dr. Sai, and thank you, Dr. Vidya, for sharing your expertise today. And the case vignette was especially very interactive and engaging, which kept us on our toes. I was hoping for more questions. And yes, it was very insightful. And again, the take-home message, yes, as Dr. Sai mentioned, check all the medications that the patient is prescribed. And the safety profile is more important than treating the disease totally, treating the mania totally. We should focus mainly on the safety first because the treatment itself can complicate or the polypharmacy can further increase the difficulties with cognition, fall, and other neurocognitive disturbances. Now, I would like the floor is open to questions. The moderators, please.
I think Dr. Vidya, very comprehensive presentation, very well, I think, summarized by the chairs. From the chat box, we could see there are a subset of questions. First, actually elaborate on the BS criteria, and subsequently, Dr. Vidya, which, like, supposedly many patients we would see will get licensing calls that are maintaining on clonazepam 0.5 mg or alprazolam and long term, and then reflexively reduce them, reduce these or stop these drugs, or benzodiazepines, and then the brain goes in absolute chaos and subsequently challenging so many things in context of old age psychiatric disorders. So, like, how to go about it, because guidelines would guide us differently. So what is your take on it?
Yes, thank you, sir. Yes, as I'll start with this question of yours regarding the benzodiazepines, what we get during the consultation. Am I audible?
Yes, yes, yes.
Yes.
Yes, please.
Yes. So in the consultation license, definitely yes, as you mentioned. Even otherwise, when we get many patients, we do get a lot of patients in my department where those are of survivor cohort who are already on benzodiazepines. They are on benzodiazepine for years together. So it is very difficult to taper the benzodiazepine dependence. Where I think it is definitely, as we all know, it is completely different than the tapering of what we do for alcohol. Here, probably it is, if it is, less than 25% of the drug benzodiazepine, we will shift it to long-acting one and then start tapering. Maybe it would take not less than 2 weeks to, we'll continue at least 2 to 3 weeks on the same dose and then attempt another dose of tapering. So usually this benzodiazepine tapering takes at times up to 4 to 6 months. It may not be possible in one go. So definitely that is the challenging thing what we face. Yes. So, what was the second question?
Basically, as per your deliberation, we have to basically take it from case to case basis. So we have to
Yes,
see
that is applicable probably for all the cases. As I mentioned, that person-centered approach is definitely needed in every case.
And BS criteria, how much duration does it allow actually to continue a benzodiazepine?
2 to 4 weeks, sir. But the issue is that when BS criteria is not applicable if the patient is, there are certain exceptions for that. So if someone is in the palliative care, then we wouldn't follow the BS criteria. But otherwise, yes, we will taper it in 2 to 4 weeks time.
Okay, okay. And another subset of questions is, like, neurobiologically, how an old age bipolar disorder in terms of late onset, but without any like SOL,
Structural abnormalities, probably.
any neuroimaging doesn't pick up. So what are the neurobiological differences per se with early onset bipolar or routine onset bipolar disorders?
Yes, this is one thing, probably this I did not mention in the presentation. So when we go for neuroimaging, yes, if the structural abnormalities are present, that they are very dramatic. But there are certain subtle abnormalities, that is like white matter hyperintensities, which are very common in older age bipolar disorder, which some of the researchers have also named as vascular mania. So these do not have any diagnostic significance, but definitely they have prognostic implications. So these come up with the more cognitive effects as well as more resistance to treatment and subthreshold symptoms, subsyndromal symptoms, they persist over the time. I think this is one significant change which we notice in older age bipolar disorder.
Okay, and mostly brain is more, you'll find
atrophied.
Atrophies and all in
Yes.
nonsense.
Yes, atrophy probably would be probably it would be happening in every aging brain, but white matter and hyperintensities is something which is distinct and important in old age bipolar disorder as such.
And regarding evidence, because Jerry BD trial you mentioned in your presentation, only 9 weeks duration of trial. So the evidence is not there specifically, seeing the
Yes,
response of various psychotropics or anti-manic agents in context, in control settings in this age group. So you're saying that most of the evidence is extrapolated from the other group.
adult population.
So the principles largely all also remains the same. So as per your discretion.
Regarding the treatment, you are saying, sir? Yes. Yes,
So
regarding the treatment, definitely it is more or less the same. But only thing is that, as I said, it is tolerability and safety. And even about tolerability and safety, the available few studies, they say that, okay, we can go ahead and with the age specific physiological adjustments, what we have to make for the dose that go slow and start low, go slow things. But the patient population which are included in these trials, they are the chosen um, population. They are the ones who have a very specific criteria. Their renal functions are not really affected much. They may be still having EGFR around maybe 60 and above, but that may not be the case in the real life scenario. So this is one challenge what we definitely face. So.
And you talked about vascular mania. So any specific treatment modalities you'll prefer, like group of mood stabilizers or any antipsychotics in vascular mania
Yes.
context?
As such, vascular mania as such is not a diagnostic entity as of now. It doesn't have any nosological status as of now. But and similarly, there are no specific guidelines or anything. But only thing is that further episodes of vascular insults can be prevented by giving aspirin. That is something which can be prevented. So otherwise, other than that, lithium is not very effective in vascular mania. So it is better to go for anticonvulsant mode stabilizer, that is valproate. So these are the differences I can think of.
Achha, Dr. Vidya, like post-COVID, a lot of patients went through this crisis of, and then a lot of them had steroids, and we got a lot of calls in steroid-induced mania. So what are your
Absolutely.
strategies to control it? Like any specific thing which works in these cohorts?
Sir, it is the root cause. So if it is feasible, as soon as possible, we decrease the dose of steroid. And then definitely, I would prefer just going for antipsychotic, atypical antipsychotic, and do not add any other mood stabilizer. And just atypical antipsychotic and maybe even not for a longer period of time. Once if the symptoms are, most of these steroid-induced mania, what I have seen, the symptom control has been very quick. So I wouldn't continue the prophylaxis for longer time in these cases. I'll attempt tapering maybe after, say, 3 months or so.
So in continuity of this, parallelly, a lot of patients are on, specifically in our area, so they are on a lot of Ayurvedic formulations, herbal formulations. So, and you must be dealing with, as a geriatric psychiatrist, in cognitive deficit domain also. So role of or risk of abusing these like reserpine or any heavy metal toxicity, when to suspect that? Can you elaborate on this?
Yes, I have read few case reports about this ashwagandha and Brahmi. I have not read anything. Yeah, there was one case report regarding that these induced psychosis based on these. Uh, but in my practice, I just say that these are medications. These would have side effects, and they would have their own interactions with the medications what we prescribe. So I just politely discuss with the patient party and attempt that probably this needs to be tapered off and stopped. And the tapering, we do not have any guidelines on that, but over the practically maybe over a week or 2 weeks, I ask them to taper it off.
I think interestingly in your presentation, you mentioned, Dr. Vidya, about valproate, like being toxic despite the levels being in therapeutic range. Can you elaborate on this? Because we would always correlate toxicity with therapeutic range, or we are dealing here with the side effects. Like so, the brain is more sensitive, the cerebellum is more sensitive to subtle levels of valproate, or we'll still use toxicity here.
Sir, definitely. See, what I would say, it's not only for even now, in our ward, in the ward where I work, we have a patient who is admitted with lithium toxicity, and it's been more than 4-5 days now, and of stopping lithium. Lithium, when she came, it was 0.282. All the lithium toxicity signs, which are moderate to severe lithium toxicity signs, but lithium is in the therapeutic range. As I mentioned in the presentation, the serum to brain, blood-brain barrier is affected. So because of that, the lithium which is reaching the brain is more. So that is one thing. And another thing is that these are chronic toxicities, sir. These are not the acute toxicities, what we see in adult age groups. So here, the GI symptoms are not very common. It is the neurological toxicity which we are talking about here. So most of these serum range here remains normal. They are not very high. And despite that, why I would say that they are not just side effects, the signs and symptoms are very classic of toxicity signs. It is the coarse tremor, what we are talking about, the ataxia, what we are talking about. It is the confusion, what we are talking about. In adult, probably we would see that this would occur only where serum lithium reaches maybe 2.5 or 3 or so on. But maybe valproate, we would see it only when serum range reaches 150 or 200. But that is not the case here. The same symptoms we see in elderly at the therapeutic range. And with the valproate, of course, it is highly protein bound, and the pharmacologically active molecule of valproate is the free one. So here, because of hypoalbuminemia in elderly, the free levels are higher. So because of that, even if you're getting the total valproate level done, maybe it is in the normal range. And if you get the free valproate level done, it may be at the higher range.
Okay, my last question,
That
because Bodani sir is getting angry with me. My last question, sir's question. The lithium, you said albumin, its valproate levels are disturbed by albumin levels. So whether this similar scenario applies to lithium, and then I'm done. Yes.
Sir, with regards to lithium, I think it is, as I mentioned also, it is there is one study also that serum lithium level and what reaches the brain, it's usually 50%, but in elderly it is way more. So what we get as serum lithium and what reaches the brain, they are different. So this is one significant difference. But regarding that, I don't think there is any different kind of estimation. It is the simple serum lithium estimation only.
Okay. Alim sir, Vishal sir.
Yes, sir.
Cover all the questions in the chat box. Shobit and Vishal, please cover all the questions.
So Dr. Paresh asked
Rapid fire.
Dr. Paresh asked question. When endoxifen should be used in OABD?
Yeah, endoxifen, yes. We have been using endoxifen, especially in where we feel that in patients where we think that lithium would be useful in cases where we get late onset mania and we are tempted to use lithium, but renal functions are affected. So that is one place where I would think of using endoxifen. Where there is significant impulsivity, there I would think of using endoxifen. And also for rapid symptom reduction, if the patient is having indications for admission, but they're not willing for admission, then I would still think of using endoxifen.
And how much dose, if I may add?
It's 8 mg, and if the patient is tolerating, then I would go for 16 mg.
16 also. Okay. What would be the, Dr. Kaveri Nikhil Chogle has asked, what would be the treatment modalities in old age vascular mania?
I think we have already discussed that.
Okay.
Yes, Dr. Shobit sir also asked the same question.
One question is left, sir, in the chat box.
Dr. Kabir?
That is, any alternative to benzo for insomnia in old age?
Yes. So alternative, one thing I would, if at all I have to use benzodiazepine, I would go for the short-acting benzodiazepine for short period of time. The second thing, of course, is the Z drug, zolpidem. We do use, but as far as possible, it is to be avoided. And another thing which we comfortably use is melatonin. And of course, depending on from case to case basis, if you are using atypical antipsychotic, something like olanzapine, that takes care of the sleep. And apart from that, yeah, low dose quetiapine, that also takes works.
And your comments on lamborexant?
Lamborexant, sir, I have used definitely, but my experience has not been great as such, so I have not been using it. Yeah, that is one option which you can think of, definitely. If anyone has the experience, probably.
Okay. Is lithium level affected by albumin level in elderly?
Sir, yeah, I think this is also the question which Shobhi sir also asked. This I have not come across these kind of studies as often what I have read, but and also I have not seen any other ways in which the lithium can be measured and which can be changed. This I have not come across. The only thing what I've come across is, of course, we know that valproate has this kind of a thing. If maybe if seniors may be able to, maybe Dr. Sai, if you are aware of this kind of a thing.
As far as I remember, lithium is very less protein bound, only I think around 10%. So I think it doesn't affect as such, but as you mentioned earlier, the blood-brain barrier becomes more permeable to lithium. So that is why even in the therapeutic range, the lithium toxicity affects more, even it is.
Dr. Preetha Roy has asked, often we find geriatric patients dependent on years on low doses of benzodiazepines, right? How to go about in those cases?
Yes, I think, sir, we have discussed that.
I think she has discussed this.
I think so.
It's extremely.
So Shobhit did ask all the questions.
Yes, we shift slowly. Shobhit sir has been my SR, so I have. So
Vidya, tell me, in clinical presentation, recent onset in OABD and a person who is past diagnosed. So any clinical differences is there?
The clinical presentations I did mention in the my presentation as well. Yeah. One thing is that, yes, only thing is that it is many times it becomes very difficult to differentiate this hyperactive delirium and manic episode. This is one thing which I find very challenging, that we all, it is like, many times it is like the presentations like delirious mania. Of course, it is again not a nosological entity. It doesn't have any nosological significance as of now. But yes, we do see such cases in elderly population. And other than that, the episodes over the time mellow down. The severity of the symptoms come down. Inter-episodic recovery may not be great. It also, the functioning depends on the physical health and cognitive status. And apart from that, many times depressive episodes present as psychosis and as presentation with catatonia, where maybe depressive symptoms emerge only after we treat with antipsychotics and there is some improvement in psychosis. Then we get to see the depressive features, and also the patient is able to say that even in the onset, it was the depression which started first before the psychosis. And these are the symptoms these are the differences I can think of.
Thank you. Any comments on the frontotemporal dementia, recent onset behavior changes and differentiating from, can we differentiate it from bipolar?
Definitely, sir. This is one important thing. I think this is what we learn as DM geriatric psychiatry senior residents. I think sticking to the basics, starting with a very good history. In onset mania, it is usually acute. Frontotemporal dementia, it is insidious. And apart from that, also we go for things like in frontotemporal dementia, it is more of a jocularity. But in mania, it is the cue induced. The patient is interactive and the patient wants to have over familiarity. And in frontotemporal dementia, it could be the disinhibition, hyperorality, and social cognition is affected in frontotemporal dementia, but it may not be the case in early signs of mania. And mania, usually in the early stages, they are usually, they respect the social hierarchy. And apart from that, executive functions which are affected in frontotemporal dementia, and that is not the case. And even the self-care, hygiene, this might be getting, the person might be getting negligent in frontotemporal dementia, but in mania, it may be the person is more self-conscious, caring for self-care is increased, more seductive kind of histrionic kind of behavior comes up, flamboyant kind of behavior comes up. Yeah, these are the things which I can think of.
Suppose Dr. Vidya, same patient with BPSD in context of FTD coming with jocularity or familiarity. So then it's a management, how you'll manage that?
Sir, when it comes to frontotemporal dementia, there are very few management options what we have. So if there are any reversible things that we will look for, if it is frontal lobe syndrome, maybe if there is anything other than underlying reversible cause that we will look for, and maybe in once we will take time, probably in the cross-sectionally, we may not make that diagnosis of frontotemporal dementia. Whenever we are suspecting, we will observe longitudinally, we will observe the patient, and if it is imaging also confirms the possibility of frontotemporal dementia, then I think we could behavioral management in that. Counterintuitively, it is SSRI which works there better than any other antipsychotics. Antipsychotics do not work.
Ma'am, I would like your view on this comment by Dr. Rajiv. He says the lady in your case, Vinit, with mania is probably hyponatremic encephalopathy. And once the sodium is corrected and sodium and this antihypertensive medication is addressed along with infection, she should be okay. So how do we differentiate that it is hyponatremic encephalopathy, or is it older age bipolar disorder in this case, Vinit, which we discussed?
See, older age bipolar disorder, she has bipolar disorder, which is, bipolar disorder is the long-term, it's a lifetime diagnosis.
Yeah.
So in this patient, what in the case vignette, definitely patient has severe hyponatremia. So it would have its own, it would cause, if there were not to be having any other problems, still the patient would have gone into encephalopathy and would have had delirium. But in this case vignette, there were multiple factors. It's not only hyponatremia, there was infection. Probably infection was causing hyponatremia. There was lithium toxicity along with hyponatremia. And probably dehydration also. So all these things together was
so we will say it's a switch to mania, or is it delirium?
It was delirium, because in the follow-up, that is what we saw.
Okay.
It was even in the first instance, probably what the case vignette what I shared, we did not increase the dose of lithium. Probably we can think that if we had thought of increasing the lithium, probably we would have even lost the patient by the time the patient returns. Yeah, it's always better to err on the side of diagnosing delirium rather than mania or any episodes in older age. When it comes to OAVD, because the episodes are not severe. The aggression, especially in elderly, is not what we see in adult population. The aggression is usually manageable with way lower dose of antipsychotics. So yeah, it's delirium if we miss, that is more problematic. That we are missing a medical emergency.
Thank you. Thank you. Have we covered all the questions?
Amrit sir has asked the last, and gender differences in bipolarity.
Sir, with the age, it is, once one crosses the menopausal age, a woman loses all the protective factor. It's something like that. So yes, the women, it's the definitely number of older age bipolar disorders are more common in women. So I think it's about 70 to 70% are women. That's what I remember reading. So yes, and even otherwise, it's those converters. They are also more in women than men.
I think, sir, one
Oh,
more question by Dr. Kabir is left. Is there any ethnic issue or differences in geriatric mania? Because in context of schizophrenia, we know there are no differences cross-culturally.
I
Is
have not read any of such studies, sir. To be frank, I have. This is an interesting thing to look into, but I have not gone through this particular area. If anyone knows about it, we can discuss. I would like to learn.
Thank you. Thank you. I think we've covered all the questions now, so we should start winding up.
yes.
So, you have given take-home messages, 4 or 5 lines. Vidya, what should we remember?
The older age bipolar disorder is, I think, to start with, you said bipolar disorder in elderly. It is not just bipolar disorder in elderly. It is different. It is a distinct entity, and it poses distinct therapeutic diagnostic challenges. And one particular thing I would think that precipitating factor, it's mostly it is medical. There would be, even in the case of older age bipolar disorder, episode would be precipitated because of some underlying medical cause. It could be infection, commonly urinary tract infection, or it could be pneumonia, or some underlying dyselectrolytemia. These can precipitate older age bipolar disorder episode. And apart from that, I would think about lithium toxicity happening at the serum, therapeutic serum level. And apart from that, I would also say that psychoeducation, which is extremely important, and as important as what I said is brown bag review, where we also attempt de-prescribing. So less is more. Yeah.
Thank you. Thank you. Thank you so much. Over to chairpersons for their winding remarks. Then we close the session with Amrit. Chairpersons, please.
Yes, I think that was an excellent presentation, and even we learned a lot of things. We'll look at older age bipolar disorder in a different perspective. And thank you, Dr. Vidya, for the wonderful presentation.
Thank you, Dr. Vidya, our moderators, my co-chair, and all my esteemed colleagues. This was really like an eye-opener because we many a time just consider bipolar in elderly just for an age. But yes, because of this topic, I also read a lot about it, and we came to know कि बहुत सारी जो comorbidities को ध्यान रखते हुए, safety profile को ध्यान रखते हुए, we have to manage this. Recently, yesterday only, I saw a patient who was on 30 years lithium. She was taking lithium without the prescription, and she had a cellulitis in her arm, and she landed up in ICU, and her lithium levels were high. But even when they got into the therapeutic range, the symptoms did not go away per se. So the important points that ma'am highlighted, that even in therapeutic range, we have to consider, we have to focus more on the science. That was a learning point for me. And I thank her again, and I thank all my esteemed colleagues for this seminar. Thank you, everyone.
Thank you. Thank you, ma'am. Oh, Amrit, over to you.
Yeah, thank you. I think we learned a lot today about bipolar, in old age, elderly. First of all, the diagnosis, the presentation, it's much more common than we were taught at. When I was in CIP, what we were taught at, what the textbook tells, the clinical experience currently speaks otherwise. We see a lot of people who are coming first episode at the age of 65, 70 even. It's very common now. It's not an uncommon entity anymore. The way you simplified things, you talked about the differences. That was great, and the case vignettes and all. So Vidya, thank you and congratulations for a brilliant presentation. Our chairpersons were wonderful, Dr. Neha and Dr. Sai. Dr. Shobit was very inquisitive today. He was asking a lot of questions, and
He got a scolding from Dr. Amrit. Badani, sir.
That is great. And thank you, Dr. Alim and Dr. Vishal. We're in the East Zone conference, me and Tufan sir, but I had to hear Vidya. So thank you again. Thank you for a wonderful session. It was badly needed. I think we go back stronger, wiser, and more older after this presentation. Thank you so much. Good night. Good night again.
Good night.
Thank you.
Good
Thank
night,
you,
sir.
everyone.
Good night.
Thank you. Thank
Good
you,
night.
Vidya,
Thank
chairpersons.
you.
Good night. Good night.
Thank you.
Ending the
everyone.
session.
Good night.
Thank
Thank
you.
you.